This is the 7th in our ASPA FLEX webinar series, and our title today is Minimally Invasive Surgery in Neonates, Infants and Children. I'm your moderator. I'm from Malaysia and my name is Usha Nair. Our three speakers today on this topic are Dr. Nada Sudhakaran from Malaysia, Dr. Fauzia Khan from Pakistan, and Dr. Felicia Lim from Malaysia. We hope this will move smoothly, and I will have help from Dr. Erlinda from Philippines with the Q&A session towards the end. You may send in your questions and comments into the Q&A section, and please be reminded that the chat and raise hand function are disabled. We will try and highlight your questions at the end to the appropriate speaker during the panel discussion. And some questions, for lack of time, will be answered by text by the appropriate speaker in the Q&A section. At the end of the webinar, please fill up a post-webinar survey, which you will find at the bottom of your screen. And if you click on that link, you will be connected to a survey. Fill up the survey and send it in. Please remember to type in your full name and email correctly as you registered for this webinar. You can also look back on this talk, which will be uploaded onto our ASPA website. You can find us in Facebook, and we will also load this video on YouTube. We hope that you will enjoy this session. Dr. Erlinda Oracion is my co-moderator and IT help from the Philippines. Our first speaker today is Dr. Nada Sudhakaran, who is a pediatric surgeon and urologist from Kuala Lumpur. He's attached to Pantai Hospital, Kuala Lumpur, Glen Eagles, and the Prince Court Hospital. His interests are minimally invasive surgery in children, and he's a trainer in minimally invasive surgery as well. Please welcome Dr. Nada. Thank you.
Good afternoon, everyone. Thank you, Dr. Usha, for the kind introduction. This afternoon, I'll be talking about minimally invasive surgery in neonates, infants, and children. The overview of the talk will be one, why minimally invasive surgery, general issues with MIS, anesthetic concerns, modifying the standard working environment, what MIS does with as opposed to open surgical approach, specific skills required by anesthetists, and I'll discuss 3 or 4 procedures specifically so that you have an idea of what we are discussing about. So why MIS? It's because we perform minimal incisions. With the minimal incisions, there's less pain, faster recovery, and discharge from hospital. There's also less scarring outside and inside in terms of adhesions. So basically, the issues and general concepts or conception of MIS, one is that setting time is long. Secondly, the overall duration of surgery is about 15 to 20% much longer than standard open surgery. There's also equipments that can be crowding around the theater space. It usually requires general anesthetic and preferably endotracheal intubation. So the anesthetist can get involved in the MIS. They can see the procedure on the screen and follow the whole surgery and anticipate if there's any problems. So the anesthetic concerns, this will be discussed by my fellow speakers later on, mainly about physiological disturbances, the pressure effect of the gas insufflation versus the ventilation, carbon dioxide retention, and also decreased venous return because often there is pressure on the IVC. The insufflation I use is usually slow in terms of the initial induction. It's slow because you don't want too much of a physiological change initially because that can cause problems with the ventilation and also the vascular supply of vital organs. In terms of laparoscopy for neonates, I usually do not go above 8 millimeters mercury. And for most children, it'll be about 10 millimeters mercury. For older children, for often above 12 years of age, it'll be up to 12 millimeters mercury. For thoracoscopy, I often don't use gas insufflation for procedures such as empyema or if there is one lung ventilation. Most of the procedures in the chest can be done with pressures of 3 to 4 millimeters mercury. So I usually run or purge the system, the tubing with carbon dioxide before I attach it to the port attached to the child, so that there's no gas or there's no air in the system, because air, especially nitrogen, is hard to get rid of in the abdomen or chest, and that can cause later some pain due to the pressure on the diaphragm and also shoulder tip pain. The gas ideally should be warmed, and when you introduce the gas, you should identify areas where there, for example, open vessels. In neonates up to the age of 3 months of age, the umbilical vein can still be patent. So when introducing gas, you must identify the vein and make sure it's away or it's ligated before you introduce carbon dioxide into the abdomen. Bradycardia can be vaguely mediated by disturbance of the viscera. The question about ET tube or laryngeal mass, often it's safer to use ET tube as opposed to laryngeal mass because you have more control over the ventilation. In terms of muscle relaxation, most surgeons would like muscle relaxation, especially with abdominal work, because it makes the space much wider, and for that you get the surgery done much quicker. So port site pain is an issue, especially in the umbilicus, where we make the initial port for the laparoscopy. So all these sites, I infiltrate local anesthetic quite liberally so that there's no pain afterwards. So you go through the different layers, the preperitoneal fat area, the muscle, as well as the skin. Chordal anesthetic is acceptable provided that the surgeon and the anesthetist have a discussion prior to the surgery to see at what level the chordal can cover, so that the port site doesn't go above this level. This is an example of infiltration of local anesthetic for the port site. So you can see here that the needle goes into the preperitoneal space, and then you can get expansion of the local anesthetic into that space. And then the incision is made with the scalpel right through. And then the instrument is introduced directly into the abdomen. You can see here that the gas pressure is 10 and the pressure is 0.5. I purge out the system so that there's no air in the system. And finally, when we finish the surgery, making sure that all of the carbon dioxide is removed from the abdomen to prevent subsequent pain. So modifying the standard working environment compared to the open surgery. Often with the tubings and with the surgical equipment, the anesthetist is remote from the patient. So access to the tubes and intravenous line should be available for the anesthetist. So everything needs to be planned nicely. There's also compromise of vital functioning such as the lung, diaphragm, and also there could be oliguria or anuria in some situation, and therefore the urinary output cannot be a good measure during the surgery. So what does the anesthetist require specifically? Monitoring is essential. Being vigilant about every detail of what's available for you, the blood pressure, etc. So in terms of thoracoscopy for neonates, the ability to assess hypercapnia is essential, because very slight shifts can happen and need to be vigilant for that. For longer and complex procedures, ideally to have more than one IV line, And if complex thoracic procedure is done, arterial line for monitoring is required. Scales for bronchoscopy for single lung ventilation, usually with bronchial blockers or selective bronchial intubation. So bronchial blockers would be the side, the epilateral side of the surgery. Bronchial intubation will be the contralateral side. So the other skill the anesthetist need to have is to communicate with the surgeon, and also if very worried or concerned, to sound adequately to the surgeon so that they might convert the procedure to open. These are the equipment used for single lung ventilation. Here is a bronchial blocker. So specific procedures that I'll discuss: inguinal hernia repair. That's something that I do very regularly. Although it's regular, it's something that's slightly different from the position that we are used to for open surgery. More complex procedures such as diaphragmatic hernia, esophageal atresia, and thoracoscopic lung resection. These are all complex procedures that the anesthetist may need to be vigilant about. This is a standard situation or positioning for patient where the head is on the side of the anesthetic machine. So this is quite simple for the anesthetist to get access to the patient. This is a procedure for cholecystectomy that's been done. In terms of the inguinal hernia repair, it's different from what I just showed you. The position is supine, but the head is on the opposite side of the anesthetic machine. The tubes are running alongside the child and well protected so that the surgeon or his assistant doesn't knock the tubes and cause dislodgement of the tubes or even detachment of the tubes. And it should generally feel slightly out of control because the patient is away from the hidden is away from them. Although this is a short procedure, it does cause a little bit of anxiety. So this is a typical scenario in a theater for a hernia repair. So the child's head is this way and the anesthetic machine is far away, and the machine is in between the anesthetic machine and the child's head. So that can cause anxiety because the anesthetist will have to stand away from the patient. So this is when we start the procedure. So what we do prior to the start of the surgery is that we align the patient, the tubes, the well secured into the mouth, and then run alongside the child like here, and is covered by the IncoPad. So it doesn't get detached, or when the surgeon attaches the sticky drape, it doesn't pull on the tube when they finish the surgery. So here you have the elongated IV line so that they can get access, the anesthetist can get access to the lines. In terms of diaphragmatic hernia, it's a complex operation. It's in a child who's slightly compromised with his breathing already. The position is semi-supine, decubitus position with 45 degrees or 90 degrees upwards on the ipsilateral side. The surgeon is operating from the head end. Usually, I do not need single lung ventilation because once I reduce the hernial content into the abdominal cavity, there is space to work. The procedure should be quick because there is significant amount of CO2 absorption by the lung, which I'll show some example of in a minute. And if it's going to be a prolonged procedure, I often decide to convert to open. And if you as an anesthetist are concerned, you need to sound that to the surgeon. So this is a position. So the anesthesia is here. The anesthetic machine is this side. The child is positioned horizontally across the table. The surgeon is working around here, and then the assistant is here. So all your tubings are coming this way. You have access of this space. So this is a typical picture of a child in that what's shown in the diagram. So all your tubes are on this side towards the anesthetic machine. So this was a study done and published about 10 years ago by a group in Great Ormond Street, London. So this look at the partial pressure of arterial or CO2. So the start of the operation, the peak point of the operation for thoracoscopic diaphragm repair, and at the end. So you see here that the carbon dioxide, the difference between the thoracoscopic versus the open procedure is not too different. However, if you look at the end-tidal CO2, There's a significant difference in terms of the thoracoscopic uh, procedure. The end tidal CO2 is significantly higher than uh, the open. So we need to be aware that not only do we look at the arterial CO2, we need to look at the end tidal CO2 as well. And if this carries on to go up, one of the things you can suggest to the surgeon is to turn off the CO2 and see how it works without the CO2. In fact, following this study, the Great Ormond Street team stopped doing thoracoscopic diaphragm repair. This is what we want in terms of the outcome. The child has small incisions, hardly be seen. This is about 2 weeks after the surgery. You don't usually get a big cut either in the chest or the abdomen here. We avoid that, and with thoracoscopic surgery for neonates, we avoid the long-term consequence of scoliosis, which is present in about 40% of children. In terms of esophageal atresia, this is one of the what we call the pinnacle surgery for pediatric surgeon. We enjoy doing this, and this is our specialty surgery. So the position is semi-prone with the right side slightly up. We need to secure the intubation. So here we need single lung ventilation because the lungs are normal. It's not, it will occupy most of the lung space. So the right side is the side that's accessed. Bronchial intubation is onto the left lung. So it's often hard to intubate the left side. So ideally using a bronchoscopy is good. The other option is to do a bronchial blocker on the right side. The difference between this is that once we detach the fistula, which is the usual scenario for esophageal atresia, there can be spillage of fluid into the trachea. The fistula is usually at the carina. So when you have fluid into the trachea, it will spill into the good side if you're using bronchial blocker on the right side. And as opposed to the bronchial intubation where the bronchus is reasonably secured with the bronchial tube. So the effect of spillage is not so much with the bronchial tube compared to the bronchial blocker. Also in this situation, we need the anastomotic tube to be ready into the, so that once the anastomosis is made, the anesthetist can advance the tube across the anastomosis into the stomach. So in this situation, we usually place a slightly smaller endotracheal tube over the nasogastric tube so that it's slightly more firm, so that when you push on it, the surgeon can identify the upper pouch. So this is the typical positioning of patient on the table. So we need to secure the tubes very nicely. Patient is in a semi-supine position, semi-prone position with the right side up. And this is the tube coming out of the baby. So here's side profile of this. So the tube is nicely secured. Everything is secured. This is the transanastomotic tube due to be advanced once the anastomosis is being done. So the anesthetist will make sure that everything is secured before the surgeon starts. There's hardly any space for the operators to stand, and you see a tiny baby with everything around him. So this is what we want to achieve here. You see the lower pouch, the lower esophagus, and the upper pouch being open, ready to be anastomosed. At the end, we find 3 tiny incisions and hardly any deformity of the chest. The last condition I want to discuss is lobectomy for lung malformation. That is CPAM or CCAM. So the position is a semi-supine position, which I like, at 45 degrees. So the affected side is up. The baby is strapped to the bed. Some patients, some surgeons prefer a semi-prone position. Ideally have venous and arterial lines available. Close monitoring of hemodynamics, because when we start ligating or securing the blood vessels, there can be changes in the hemodynamics of the patient, and especially if there is some blood leakage. And at the end, there'll be the bronchus will be stapled. There can be some ventilatory changes, especially if the wrong part of the bronchus or a different part of the trachea is being clamped. So that's something that we need to discuss with the anesthetist whilst I'm stapling the bronchus. There can be potential blood in the airway, so be prepared to aspirate any secretions or blood in the trachea. So this is the position. The affected side is up with a 45 degrees. So this is a video of the procedure. So you see here, there's some blebs, which is the abnormal lung. This is the middle lobe of the right side. We introduce some CO2. This is about 3 millimeters mercury. You can see that this is not a single lung ventilation. You can still get access to the tissue quite nicely. Firstly, we go for the arterial supply to that lobe, ligating as we go along. So the anesthetist will give me a feedback as to what's happening. You can see everything is very limited in terms of the space we have to work with. So firstly, we ligate and cut the blood vessels. And then once this is done, a big staple comes through. I initially apply light pressure to the affected bronchus, making sure that there's no changes in the ventilation before I staple it. You can see the staple line here. This is the lung side, and then this is the bronchus side. And then it's pulled through the small hole that we create. And here we have the lung with the bronchus side clipped, and you have the abnormal cystic lung malformation here. So overall, I've discussed a few complex cases in a common case. Overall, what's important here is communication. You need to discuss with the surgeon preoperatively, discuss about potential risk and shortfall, what the anesthetist as your side you are worried about, and we will also discuss about what the situation we like to achieve so that the operation goes smoothly. Some procedures need lots of the anesthetic input, such as insertion of the transanesthetic tube for esophageal atresia, for ballooning up the stomach for pyloric stenosis, and following that to discuss about adequate pain management for the patient. Hopefully not too much because we're doing it MIS. In summary, preoperative team discussion is crucial for planning out good, efficient surgery. Close monitoring and good understanding of potential complication as an anesthetist is important, and to speak to the surgeon whenever there's concern. So it's a two-way process between anesthetist and surgeon. Thank you very much for listening, and that ends my talk.
Thank you, Dr. Nada, for your excellent presentation. Indeed, positioning for laparoscopic surgery is quite complex, and I think we need a lot of practice to get it right. And definitely communication is important. I think so many things are hidden under the drapes, and if we don't communicate with each other, it's not going to be easy coming out with this child. Thank you again. And if any of you have any questions, please put them up in the Q&A section. Our next speaker is Dr. Fauzia Khan, who will be speaking to us from Karachi, Pakistan. She's professor and consultant anesthesiologist at the Aga University and Hospital in Karachi. Her interests are pediatric anesthesia and neuroanesthesia, and she's an advocate of patient safety. Please welcome Dr. Fauzia Khan. Thank you.
Thank you very much, Dr. Usha, for your kind introduction. I'm going to talk about the general anesthesia concerns for minimally invasive surgery in children. I also bring you greetings from Pakistan. And as far as conflict of interest, I have no conflict of interest to declare regarding this presentation. Now, laparoscopic surgery is now being used for many abdominal and pelvic procedures in both children and adults, both for diagnosis and for treatment. But there are certain key points that are different compared to those procedures that are done in adults, and we'll go through them as I go along the presentation. Now, I've kept it simple, and I'm not quoting individual papers, but these are the selected references that I've used, some of the references. There are some excellent review articles on this, some quite recent ones, and you'll be able to look at them when we upload this presentation. What I'm going to do is, first of all, discuss the physiological changes which are associated with laparoscopy. Also talk about the perioperative care during laparoscopy in children, and then what are the expected complications and their management. Advantages, some of the advantages of minimal invasive surgery have been quoted by Dr. Nada. There are several. There is less postoperative pain, there is less respiratory depression, the cosmetic results are better, there is earlier postoperative recovery, shorter hospital stay, and lower cost. The last two are quite important from the point of view of lower and middle income countries. Now, the physiological changes that are related to minimal invasive surgery in children can be divided into three. First of all, there are the changes which are related to increased intra-abdominal pressure. Then there are changes related to carbon dioxide absorption. And thirdly, changes related to postural modification. So let's first discuss what happens when the intra-abdominal pressure is raised after gas insufflation. It affects the different systems of the body, more so the respiratory and the cardiovascular system. But there are other systems that are being affected as well. So these effects are similar to those that happen in adults, but changes are much more profound in case of children. In the respiratory system, because of the diaphragm rises because of insufflation of gas, there is decrease in the functional residual capacity. There is also alveolar collapse and desaturation. Remember that in children less than 10 years of age, the closing volume is quite near the functional residual capacity, and hence the alveolar collapse, the small airways get closed, and alveolar collapse and desaturation is more common. Also, the compliance decreases, the peak airway pressure increases, and the resistance to breathing is increased. So the recommendation is to keep the intra-abdominal pressure to be limited to 5 to 6 millimeters in case of neonates and in infants, and 10 to 12 millimeters in case of older children. What about the cardiovascular system? There have been several studies done on the changes associated in the cardiovascular system. There are changes in venous return. If the intra-abdominal pressure is more than the right atrial pressure, the venous return will decrease. There is also a decrease in the aortic blood flow and also a decrease in the stroke volume. The systemic vascular resistance increases and the cardiac index is decreased. Rarely there is a vagal mediated bradycardia due to the stretch receptors present in the peritoneum. And even cardiac arrest has been reported, especially in younger children, neonates and infants. Now, these cardiovascular effects are quite challenging in those who have got fixed cardiac contractility. And as you know, neonates and infants, they rely more on their heart rate rather than in their ability to increase the stroke volume. The thing to remember is that all these changes are temporary and they're reversible once the pneumoperitoneum is terminated. Then there are changes in the other systems. mainly the renal system. The abdominal pressure causes a decrease in renal blood flow and in renal function. There's increase in the ADH secretions, and the urine output also decreases. And so urine output is not a very good indicator of fluid volume in case of these procedures. In central nervous system, there is an increase in the intracranial pressure and a decrease in the cerebral perfusion pressure, and this is multifactorial. In addition to these, there is acid-base modification as well, because the carbon dioxide that is put in, it does react with the peritoneal fluids and produces carbonic acid. So these were the changes that occurred due to raised intra-abdominal pressure. What about the changes due to carbon dioxide absorption? Of course, carbon dioxide is a very soluble gas, so it increases the end-tidal carbon dioxide, or carbon dioxide is absorbed in the blood, and then it shows an increase in the end-tidal CO2. On the cardiovascular system, it has both direct and indirect effects. Directly, the carbon dioxide decreases the systemic vascular resistance because of the vasodilatation. But the indirect effect is associated with the sympathetic stimulation it causes, and that increases the systemic vascular resistance. So it's a balance between the two. There is also direct myocardial depression, and the stimulation of the sympathetic system causes an increase in heart rate, blood pressure, and can cause arrhythmias. The neonates and infants, remember that they have peritoneal area per kilogram weight larger than the older children and in adults. Hence, there is more absorption of carbon dioxide in these patients. The third set of effects are due to positioning. Trendelenburg position is mostly used for pelvic and lower abdominal procedures, whereas anti-Trendelenburg position is used for upper abdominal procedures. So one should do padding to avoid nerve injuries in these patients, and also support should be provided to prevent sliding, like for example in the Trendelenburg position. Now we'll come to the perioperative measures that should be taken. The thing to remember is that the general principles of pediatric anesthesia should be followed in all cases. So the basic principles are the same. These children may present with a spectrum of scenarios, and when we're doing preoperative assessment, one should pay particular attention to any bleeding disorders, any congenital heart disease, any pulmonary dysfunction, and the hydration status of the child. The lab investigations, they depend on the complexity of operation and the general condition of the patient. Pre-medication again depends on the institutional practice, because some anesthetists like to give pre-medication, whereas others don't, mainly like I don't use pre-medication in my daycare patients. Okay, so what are our goals in the anesthetic management? First is to provide appropriate conditions required for surgery. Second is to rectify the physiological derangements. And thirdly, to maintain optimal saturation, acceptable arterial carbon dioxide levels, and tidal volume should be delivered with the least inspiratory pressures. Induction, again, depends on your choice. It can be either intravenous or inhalational induction. One should avoid distending the stomach during mask ventilation. And if it happens, then decompress after tracheal intubation. IV line should preferably be placed in the upper extremities because of the effect of intra-abdominal pressure if it's placed in the lower extremities. Intubation, cuffed versus uncuffed tube, both can be used, but cuffed tubes have advantage because if you need to increase the ventilatory pressures, the leak is much less in these cases. Also, you can apply PEEP if you're using cuffed endotracheal tubes. Use of supraglottic airway devices, even the second generation devices, it is controversial and there's a debate about it. An orogastric tube should be placed if you haven't placed it before, after ventilation. And then the technique could be inhalational agents with either air or oxygen, or total intravenous anesthesia, depending on the choice of the anesthesiologist. Use of nitrous oxide is again controversial. And if used, it should be discontinued after induction. This is because of its effect on the intestines, because it replaces the nitrogen there. And neuromuscular blockade and adequate relaxation is the requirement. A few points about intra-abdominal pressure. It's important not to exceed the intra-abdominal pressure of 6 millimeters of mercury in newborns and in infants, and 12 millimeters of mercury in older children because of the physiological effects we've just talked about. Newer insufflation equipment have pediatric settings that limit the maximum pressure and also the flow rate during insufflation. And a slower rate of insufflation is recommended in younger children. In a 10 kilogram child, they only require about 0.9 liters gas volume, whereas in adults, this is about 2.5 to 5 liters. The technique of choice is positive pressure ventilation with neuromuscular blockade. And with modern ventilators, lung protective and volume targeted ventilation is possible. If that is not available to you, pressure controlled ventilation is used. But remember that with the increased insufflation pressure, you have to alter your pressures at times. The tidal volume and the respiratory rate is adjusted to maintain normocarbia. Monitoring for surgeries like inguinal hernia or diagnostic laparoscopies, etc. The monitoring is routine. Blood pressure, non-invasive blood pressure, ECG, oxygen saturation, capnography, and core temperature. But any additional monitoring will, of course, depend on the complexity of the procedure, the medical condition of the patient, what is the expected blood loss, what is the duration of surgery. In a recent paper from Argentina, where they do a lot of pediatric laparoscopic surgery, and they've done quite a few cases in neonates, they're recommending invasive blood pressure monitoring and use of NIRS in neonates as well. Analgesia, I'm going to leave to Felicia, so I'm going to skip the next couple of slides and come to temperature control. Now, core temperature of these kids drops if insufflation gas is cold. So one needs to take both passive and active measures, covering the areas that are not going to be exposed well. But the newer laparoscopic sets do provide warm gas. So incidence of hypothermia is not that much with the newer apparatus. In fluids, the goal is to maintain normovolemia. Remember that compared to open surgical procedures, there are much less fluid shifts in these children. They've got minimal third space losses and decreased evaporative losses. So adequate intravenous fluids are required to ensure an optimal preload. And this is especially important in case of neonates, as I mentioned earlier, due to their physiology. Emergence, adequate reversal of neuromuscular blockade, and normocapnia must be ensured prior to extubation, because if the residual carbon dioxide is left in the abdomen, it gives rise to more nausea and vomiting and also pain. Post-operative care, the two main things that we are concerned with are the post-operative nausea and vomiting and pain management. So post-operative nausea and vomiting, a single agent prophylaxis in patients without other risk factors. So either 5-hydroxytryptamine receptor antagonist or dexamethasone is used. If there are risk factors present, then multimodal therapy using either both drugs together or addition of other agents is required. Post-operative pain, Felicia is again going to talk about it in detail. So coming to complications, one should be aware of the potential problems that can occur in these procedures, especially in case of neonates and infants. And in one publication, the incidence of recorded complications has been given as 5.38%. The problems that can occur during insufflation, these are decrease in the oxygen saturation, transient hypotension, hypercapnia, hypothermia, and metabolic acidosis. So complications, again, can be divided into three areas. There is the effect of laparoscopic insufflation and what it can do to the respiratory and the cardiovascular system, and gas embolism can occur. Then surgical maneuvers can lead to either vascular injury or solid organ injury. And then there are the complications related to patient positioning. So what are the ventilatory problems that can occur? There can be endotracheal tube migration, especially with the position changes. There can be pneumothorax. Then there are ventilatory problems due to excessive intra-abdominal pressures. Patient position, change of position can cause ventilatory problems. It can also, there can be a decrease in functional residual capacity leading to hypoxemia. Then ventilation problems can also be related to a fall in cardiac output. Bronchospasm can occur, atelectasis can occur in these children. And aspiration, though rare, is also a possibility with Trendelenburg positions and raised intra-abdominal pressure. Hypoxemia has there are multiple causes which can give rise to hypoxemia. If you do get hypoxemia in these cases, first of all, you should think of the common problems that can occur and try to rectify those. Auscultate the chest to rule out bronchial intubation or bronchospasm, and increase your oxygen concentration. And sometimes optimizing PEEP can take care of this. If there is refractory hypoxemia, then you can request the surgeon to reduce the pneumoperitoneum. And even if that doesn't take care of it, then one may have to convert it, the surgeon may have to convert it to an open procedure. Then hypercarbia, we've talked about the physiology. The increase in ventilation can take care of that. Hypotension can occur here. Then it is, one should confirm the intra-abdominal pressure that it is within acceptable limits, and other treatable causes should be treated, for example, using higher concentrations of inhalational agents. These should be taken care of first. Viscous injury usually occurs at the initial entry or placement of trocar, and the chances seem to be more in neonates and infants. It usually occurs if there's vascular injury during the placement of a trocar, or if abdominal trauma is present beforehand, and insufflation of gas can cause, it can cause viscous injury. Pooling of blood may be away from the surgical field. So one should inform the surgeon if there is unexplained hypotension and occult bleeding is suspected. Venous gas embolism is usually subclinical. Suspect if there is unexplained fall of blood pressure, if there is hypoxemia, or if there is an abrupt fall in cardiac end-tidal CO2 levels. And the treatment is to deflate the abdomen, turn off the nitrous oxide if using it, and supportive therapy with fluid and vasopressors. Subcutaneous emphysema can occur. It usually resolves spontaneously, but it may take several hours to do that. And only patients with cardiovascular or respiratory compromise, they need to be observed in post-anesthesia care units for longer periods. So in the end, what is the difference from adults for minimally invasive surgery? As I said earlier, it's more or less the same, except for some key points. So remember that one size does not fit all. Access to patients is difficult in younger children. As Dr. Nada showed the picture, the area is crowded. Anesthetist may be away from the head end of the patient. There should be particular attention to intra-abdominal pressures. Vagal reflex is much more common in these individuals, especially the lower, especially in neonates and infants. And there is difficulty in maintaining temperature if the gas that is being insufflated is not warm. Meticulous attention to fluid requirements, especially again in neonates and infants, and frequent communication between surgeon and anesthetist is required much more compared to adults. So with this, I'll come to end of my talk, and thank you very much for your patient listening.
Thank you very much, Dr. Fauzia, for your very enlightening talk. And definitely communication is the key. And pediatric laparoscopic surgery is certainly very different from doing adults. So thank you for all that information. Our third speaker today is Dr. Felicia Lim, and she will be talking to us on post-operative pain management in laparoscopic surgery for children. Dr. Felicia is a visiting pediatric anesthesiologist at the National University of Malaysia, which is in Kuala Lumpur, and her special interests are pediatric pain management, minimally invasive surgery, as well as pediatric TIVA. Please welcome Dr. Felicia Lim. Thank you.
Just excuse me for a moment. I've lost my slide. Okay. Okay, thank you, Dr. Usha, for your kind introduction. Okay, my topic is on perioperative pain management in laparoscopic surgery in children. Now we know one of the benefits of laparoscopic surgery is there is less pain. And abdominal laparoscopic surgery is known for less pain when you compare it with that of laparotomy, because the wounds are smaller. And but the question is, does smaller wounds means less pain? Okay, there are a number of studies that have shown that many patients still complain of considerable post-operative pain, and they require more analgesic, especially on the first post-operative day. And this is a study in adults, and they assess the 24-hour pain intensity and analgesia requirement. And they found that actually laparoscopic surgery is more painful in the immediate post-operative period. The pain is more intense, and the patients require more analgesic. But by 24 hours, the pain is less. Okay, this is in adult study, but there's also study in children. And this is a retrospective study in children undergoing laparoscopic appendectomy. What they found is 1 in 3 patients experienced substantial post-operative pain on the day of surgery. And on the next day, 1 in 5 children continue to have pain. So their conclusion is substantial post-operative pain is common in children undergoing laparoscopic appendectomy. There's also another study comparing laparoscopic and open fundoplication in children. They found that the total amount of morphine is similar in both groups. The requirement of morphine during the first 24 hours is actually greater in laparoscopic group. But the period of analgesia required is significantly less in the laparoscopic group. So the conclusion is that the benefit of laparoscopic over open fundoplication would appear to be just the decrease in the duration of pain. Now, although post-operative, post-laparoscopic pain is expected to be less, there are also patients who experience a substantial amount of pain. And so the management of pain has to be addressed. Without effective pain management, this ongoing pain may cause discomfort to the patient, may delay recovery, and for daycare cases, you may have to admit the patient. There may also be increase in cost and can lead to adverse emotional and developmental consequences in children. Now, there is a question asked by the editor of Saudi Journal of Anesthesia in 2013. And he asked the question, pain management following laparoscopy, can we do better? And he stressed the need to address the problem of post-laparoscopic pain. Let's take a look at post-laparoscopic pain. The pain comes from the tissue trauma at the incision and the trocar sites. And pain also comes from the visceral manipulation and traction of the viscera. And the insufflation of carbon dioxide into the peritoneum can cause distension of peritoneum, can stretch the diaphragm and stretch the phrenic nerves and cause neuropraxia. The carbon dioxide can irritate the diaphragm, irritate the blood vessels and the phrenic nerve. And all this can cause pain in the after the laparoscopic surgery. And if there's any remaining gas in the abdomen, that also will cause some amount of pain. So all this manipulation in the peritoneum causes the release of inflammatory mediators, which also contribute to pain. Now, the post-laparoscopic pain, the characteristic is different from the pain from open surgery. There are actually three components. First is the incisional wound pain. Second is the abdominal visceral pain. This is a kind of diffuse, deep abdominal pain that is poorly localized. And then you have the shoulder teeth pain. Now, different analgesic modalities have been used with varying success to manage post-operative pain in pediatric laparoscopic surgeries. And the management modalities range from using simple analgesic, local infiltration of the wound, using of opiates, either as infusion or PCA, even peritoneal instillation of the local anesthetic. And of course, there are quite a number of regional blocks that are used. Other modality includes IV lignocaine infusion, and the newer ones like use of corticosteroid in the management of pain. Now, the types of regional block that have been used to manage the pain, one is all the nerve blocks that block the sensory nerve supply to the anterior abdominal wall. Includes rectus sheath block, TAP block, and QLB block. And of course, caudal or epidural anesthesia has been used. Now, how effective are these methods of pain management? I shall cite a few studies that I found in the journals. I won't go into the details, but just to let us know how effective these methods are. First is a retrospective study of the multimodal analgesic treatment after laparoscopic appendectomy in children. Their multimodal interventions include local infiltration at the incisional site, IV opiates by PCA, and scheduled doses of IV ketorolac and oral acetaminophen or hydrocodone. And they found that this multimodal regime reduced the incidence of pain. So this is one study that shows that multimodal analgesic help in the control of pain. And this is a paper that compares the Corda block with diclofenac suppository and local anesthetic infiltration. And they found that the analgesic, the pain score for both groups are comparable. And so they conclude that the analgesic efficacy of diclofenac suppository with local infiltration is comparable to Corda block. And since Corda block is more invasive, they suggest that the use of diclofenac suppository with local infiltration is as good and useful and more economical. And this is use of Corda block. Now we use a lot of Corda block for lower abdominal surgery, but this paper look at the use of Corda block in laparoscopic surgery of upper urinary tract surgery like nephrectomy, pyeloplasty. And they found that they have three groups. The first group have no Corda block. The second group has Corda block, just a single dose of Corda block with just 1 ml per kilo of 0.5% ropivacaine. The third group, another single dose of Corda block with 1.3 ml per kilo of 0.15% ropivacaine. And their primary outcome variable was preoperative fentanyl use. And I think we expect the result to be that Corda block with 1.3 ml per kilo of 0.15% ropivacaine provide better post-operative analgesia than the other two groups. Now, this is a study that compares ultrasound-guided TAP block with local infiltration in pediatric laparoscopic surgery. And the conclusion is TAP block is superior to local infiltration for intra and immediate post-operative analgesia in pediatric laparoscopic surgery. What about rectal sheath block? This study compared rectal sheath block with local anesthetic infiltration. And the result is that rectal sheath block is not superior to local infiltration of the wound. Now, this other study evaluate the analgesic effect of periportal local infiltration of the wound plus intraperitoneal instillation of ropivacaine. And they found that if you give local infiltration plus intraperitoneal instillation of ropivacaine is much better, is more effective for pain, post-op pain relief. Now, I came across this interesting case report, just came out recently, I think November 2020 from India, where they used bilateral quadratus lumborum block in a neonate who underwent laparoscopic ovarian cyst removal. Now, this is a neonate of 28 days old. So the anesthetist wanted to avoid using opioids in this neonate. And so instead of using giving opiates, they gave ultrasound-guided bilateral QL block. And throughout the operation, they do not need to give any opiates, just paracetamol just before extubation. And no analgesic were needed in PACU. And the other dose of paracetamol was given 10 hours after extubation. And the baby was discharged on the second post-op day. And so this is a case of where bilateral QLB plus paracetamol is effective pain relief without the use of opioids. Now, IV lignocaine have also been used in adults actually to provide satisfactory analgesia with less opioid use. And the rationale for using IV lignocaine is because it has peripherally and centrally mediated analgesic, anti-inflammatory, and anti-hyperalgesic property. But is it effective in laparoscopic surgery in children? There was this article, this study that was done to assess the effect of IV lignocaine for post-op analgesia. And the group of patients who received lignocaine infusion with a bolus dose of 1 milligram per kilo, followed by a 1.5 milligram per kilo per hour infusion. And they look at the number of patients who had a FLEX score of 4 or more, and therefore required rescue analgesia in PACU. Their conclusion is systemic lignocaine did not reduce the number of children who receive rescue analgesia in PACU. Now, what about corticosteroid? Now, corticosteroid has been used recently as pain management. And corticosteroid, as we know, it's known to modulate inflammatory response and have been shown to decrease inflammation and provide analgesia in various clinical scenarios. And in children, they have found it to be effective in reducing pain after oral surgery, spinal surgery, hypospadial repair, and oculopexy. I just quote 2 studies where dexamethasone is used as a post-op pain relief. And this in pediatric tonsillectomy, where a single dose of dexamethasone of 0.5 milligrams per kilo reduce POMB, which you all know, and it also reduces severity of pain on the second post-operative day. And the other study is on pediatric oculopexy, and again, a dose of dexamethasone of 0.5 milligrams per kilo plus CODA augmented the intensity and duration of post-op analgesia. So in adults, there are many studies that have shown that corticosteroid is effective in controlling post-laparoscopic pain. But in children, there are no studies. So corticosteroid is a promising adjunct to post-laparoscopic pain management. Now, just a little bit about shoulder tip pain. The incidence in adult is actually quite high, from 35 to 80%. It can be mild, it can be severe, and it can persist up to 72 hours after surgery. I think the incidence is highest among the gynecological laparoscopic surgery. Now, in children, what is the incidence of shoulder pain? This article looked at the shoulder pain after laparoscopic appendectomy, and they quoted incidence of 35% undergoing in children undergoing laparoscopic appendectomy. Now, post-laparoscopic shoulder pain is hypothesized to be the result of the pneumoperitoneum, and because it induces a peritoneal stretching, irritation of the diaphragm and the phrenic nerve, and so it results in referred pain to the shoulder. Now, the pain can be unilateral or bilateral, and other factors that contribute to phrenic nerve irritation is the temperature of the carbon dioxide, and any residual carbon dioxide in the abdomen after surgery will also cause shoulder pain. Now, it's been found that visceral pain usually predominates in the first 24 hours, and then it will subside. But the shoulder pain will come on after 24 hours and increase in intensity. Now, there are many strategies that have been used to decrease shoulder tip pain. All these methods have been tried in adults. Not many have been tried in children, because some of this can be quite dangerous for the children. So after I've said all this, what is the optimal analgesic regime for laparoscopic surgery in children? Now, there's a guideline from the Association of Paediatric Anaesthetists of Great Britain and Ireland. And in their guideline, they say that pain can be quite considerable particularly during the first 24 hours. So they advocate a multimodal analgesic strategy. And the multimodal can be a combination of local infiltration, opiates, NSAID, and paracetamol. And as regard to things like opiate infusion or PCA, they may be effective, but it requires further evaluation. There is actually no optimum. You have to use multimodal analgesic. Now, there's also, in adult, there's also a guideline. This is a systemic review to formulate a recommendation for post-op pain after laparoscopic cholecystectomy. Now, they recommend, again, same thing, multimodal analgesia, starting with a very basic anesthetic technique and reserve opiates for more severe pain. So the take-home message is that post-laparoscopic pain comes from the wound, from manipulation of the viscera and the CO2 pneumoperitoneum. And pain can also be, contributing factors to the pain will be the inflating pressure, the type of surgery, whether it's minor or major, duration of the surgery. And pain can be substantial, especially the first 24 hours. And shoulder tip pain can come on later. So pain following laparoscopic needs to be addressed. Now, to manage the pain, we should adopt a multimodal approach and choose the appropriate analgesic method that is safe for the patient. And the surgeon should use a minimum abdominal insufflating pressure. And at the end of surgery, there should be a meticulous removal of residual gas. So my question is, again, pain management following laparoscopy, can we do better? I think we can if we pay attention and do our part, because with the new methods that have come out for analgesia, let's hope that we can do better than what have been done before. Thank you.
Thank you. Thank you very much, Dr. Felicia, for a very informative presentation. And definitely multimodal is the way to go. And I think it's a good time to read up on all the different drugs that are available and, you know, the dosages. And in fact, some of the dosages are different from what we know. I mean, for dexamethasone, they are actually recommending using up to 0.5 milligram per kilo. So thank you so much for that. In the Q&A section, some of the questions have been answered, and some, I think the speakers would like to go live. I would like to pass over the Q&A session to Dr. Alinda, and she will take over, and we will attempt to answer everything that has been all the questions that have been put up here. All right, Dr. Elinda, please carry on. Thank you.
Okay. Thank you, Dr. Usha. Okay, we will start our Q&A portion right now. I would like to thank the speakers for very informative presentations. And certainly we do have a lot of questions. Some of them have already been responded to in the Q&A box. But for some, maybe we can highlight them as well. So I'd like first to start off with Dr. Nada. I think one of the things that was asked in the Q&A, which you of course answered already um, in the box, I would like you to highlight first of all, because certainly some would ask about why would you do laparoscopy for hernia instead of doing it open? Some would say that in the chat box, they asked about it being a way to avoid airway instrumentation. Could you expound on that and tell us why you would choose laparoscopy for hernias rather than an open procedure?
Yes, so thank you for the question, Dr. Elinda. Basically, over the last few years, we identified that the inguinal hernia repair laparoscopically is quite a simple procedure with very little risk. Although you need the endotracheal intubation. The benefit for laparoscopic procedure is you can identify a contralateral metacronous hernia. So when you're doing an operation, you want to make sure there's nothing else that's possible to happen later on. So a lot of times, surgeons who operate on children, they will try to look at the contralateral side. Some has proposed putting a camera into the sac. When you're doing one side, you put a camera to the side, look at the other side. And some who do operations on children, on girls, they would do an operation on the other side as well to check for the contralateral side. So the contralateral identification of problem is why we do a laparoscopic procedure. And in girls, we need to look at the intra-abdominal gynecological organs, making sure that there's no other problems with it, making sure sometimes you can get a herniation of the ovary, which is hard to feel. And you might ligate the vessels to the ovary if you don't identify that. So laparoscopy is, in terms of for a surgeon, it's safer and gives you more information.
Okay, thank you for that response, Dr. Nada. So I'm sure people have been are more comfortable now knowing that there is certainly a reason why laparoscopy could be better for children at this point. Now let's go to Dr. Fauzia. So one of the questions that they asked, what was asked, is that whether you would recommend atropine sulfate to overcome the vagal response. Would you like to tell us about that?
Yes, thank you, Elinda. I don't use prophylactic atropine in children anymore, and the literature supports that as well. But as I said, especially in neonates and infants with laparoscopic surgery, there is a higher incidence of bradycardia and even cardiac arrest reported. So what I recommend is have the atropine ready with you. But prophylactic atropine has its own problems. It thickens the secretions, and children may have problems afterwards in clearing their airways.
Okay, thank you very much for that. Now there's another question for Dr. Felicia. Some of them would ask about peritoneal infiltration. I guess some are not knowledgeable about this. Would you like to expound on how you would conduct? You would ask your surgeon to do peritoneal infiltration?
You're talking about peritoneal installation.
Installation, yes.
I have not seen it done. My surgeons don't do that. But from the study, what they did was to take 10 cc of ropivacaine and just instill into the peritoneum, in the abdomen.
Okay. Would you have an idea of what concentration they would instill into the abdomen?
0.5.
Probably the lowest, 0.1,
The lowest,
probably.
0.15, I think. Yeah.
Yes, 0.1. I would think it would be 0.15.
Yeah.
So how about you, Dr. Felicia, Dr. Faucia? Would you have experience on that, in the peritoneal installation?
No, not in pediatrics.
Maybe
Okay.
Dr. Nada, has he got any
Yes,
experience? Yeah.
maybe Dr. Nada.
No, I don't have any experience with this
Oh,
installation because it's quite difficult to identify where you want to install it, and of course the space is very big, and the volume required to anesthetize the peritoneum is quite a lot, I think. But if you localize an area where you think is most maximal pain, where the port site is,
uh-huh.
I suppose you can give adequate pain relief. I think the distension of the tummy is what you're talking about, what causes the pain as well. So this gradual installation of gas doesn't cause a significant stretch on the abdomen, and also the pressure. I
Yeah.
think that those are all key features of how you reduce pain.
Mm.
Okay, very good. Thank you very much for your answers. So, Dr. Nada, if I may go back to you, since all of you discussed how communication is really the key to a good outcome, I'd like to know, therefore, that if you are deciding to do laparoscopy on children, would you suggest doing a multidisciplinary team conference prior to surgery, or would you just suggest just talking amongst yourselves? Or would you have a formal team conference?
Yes, I think for something like a complex esophageal atresia, we usually sit down together. So my experience is that, so get the anesthetist, the neonatologist, and the team. So if possible, the rest of the team, the nursing staff as well. So to talk about how we're going to set up and what are the issues that we each other face. So we lay it out so the planning can be done on every perspective. Yeah. So that's a better situation. Sometimes we don't have time for that, for a
Mhm.
severe disease, and it's sort of a sudden thing. You can't plan for it too much. So within a day, you should get the surgery done. So we don't have time to plan so much. In that situation, as much as planning is required, and then face-to-face planning is better, I think.
Okay, but definitely what is really important is that you talk to each other, right? That's what
Well,
you all of you have been trying to say.
generally nice than is just
Okay, so you have to be nice to the anesthetist as well. All right.
mine is
Okay, so if I go, okay. So Dr. Fauzia, in relation to the question on atropine, could you expound a bit more on the difference of the anesthetic management for neonates in MIS? Because you said also in one of your messages that the vagal response would probably be seen more in neonates rather than in older children.
Yes, Linda, the thing is, all these changes that have been described are more complications can occur in case of neonates. And one thing to remember is that neonates may have transitional circulation, and increased intra-abdominal pressure can cause reopening of fetal shunts. So hypoxemia can be much more in these patients. In addition, they've got, as I said earlier, relatively fixed cardiac outputs. So fluid management is crucial. And maintaining the preload is crucial in these patients. Then they're also more prone to hypothermia compared to older children, and also hypercapnia, because the peritoneal cavity area per kilogram of weight is much more compared to the older children. So these are some
So
of.
really,
Mhm.
it's really tricky, right? When you deal with children, all the more with
With
neonates.
neonates, yes.
Yes. So, Dr. Felicia, now that we have talked about that, there was a question about the use of dexamethasone. There were certainly a lot of questions regarding the dosage, but this was answered. One asked about the use of dexamethasone after induction for reducing PONV and reduce inflammation. Question is, can it be used for 3 days? And what is the efficacy now of dexamethasone to reduce pain starting the second day?
Yeah. The use of dexamethasone in children for pain has not been studied very much. So there isn't any study that I could find for use in this laparoscopic surgery. What they have is just one single dose intraoperatively, and in other surgeries, like, I quoted tonsillectomy or kidopexy. And I also realized that their dosage is actually higher than what we are used to, 0.5 milligrams per kilo. And so nobody knows exactly, unless somebody start doing some study, and we'll know how much we actually need and how effective it is. And to give 3 days is a bit,
Yeah.
probably wouldn't do that. Yeah.
Yeah, probably.
Yeah.
Okay, thank you for your answer. And certainly, as I said, when you use dexamethasone, it seems like it is a wonder drug. You can use it for PONV, anti-inflammatory. Now for pain, I guess it actually treats the pain of the inflammation more. It's probably related to that more than anything. So maybe since for all of you out there who are interested in doing studies, this may be a study to look into if you would like to try to use dexamethasone on another day, a second or a third day. But now, if I ask all of you now, there was a question on perioperative neuropathy. Since positioning is very something significant for all of us working on a patient for laparoscopy, would you have any data about this perioperative neuropathy due to positioning in laparoscopy? Maybe we can go with Dr. Nada. Would you have anything on that?
Sorry, I was doing the question and answer. What was the question?
Okay, it was about the data on perioperative neuropathy due to the position, such as when you do your lateral liquid, because you showed a lot of photos on the
Oh,
positioning of
yes.
children. So,
So
do you have some data on that?
So there is no data per se, but of course, we are very concerned about the way we stretch things as well. So the child, you can see, is very well padded. So from top to bottom, where we don't need to expose, it's all well padded. We also use gel pads all throughout. So anywhere there's contact to hard surface is gel padded. And also we worry about stretching of the arm, so the brachial plexuses. So especially in the severe atresias, diaphragmatic hernias, we have the arm above the head. So that's all on gentle. Just leave it on and tape it in position without much stretch. So those are all crucial. So especially in babies, fortunately, I have not come across any situation myself where there is any neurological issues in my patients. But I think that's
Mhm.
something that's been reported in the literature. But I think it's very few and far between. It's not. I don't think that's one that's reported heavily. Even with the open surgery, severe atresia, they used to hang the arm on the bar across, isn't it? Have you come across that? So
Yes,
that also
that's
causes
right.
brachial plexus stretch. So even in the past, we are very careful with the open surgery, very careful about stretches in the arm and any other structures.
Okay, how about Dr. Felicia? Would you have some data on that?
No.
No. And Dr. Fauzia?
Yeah.
No personal data, but there are a couple of papers which talk about complications in general.
Mhm.
But
Yes.
I think it's relatively rare, so there must be case reports rather than the numbers.
Okay. Thank you for that. And Dr. Fauzia, since I'm with you right now, could you now tell us how we could identify gas embolism during surgery, and how would you deal with this kind of a problem intraoperatively?
Okay, the signs of gas embolism would be, like for example, any other surgery, like neurosurgery. A patient will become hypoxic, patient will have hypotension, but then the other causes must be ruled out. And then I think most important sign is the sudden fall in carbon dioxide tension, entitled CO2. So because there is a ventilation perfusion mismatch, so that's one way to diagnose it. But for hypoxemia and hypotension, you have to rule out the other major causes. If that happens, you of course inform the surgeon, you request them to deflate the abdomen. If one is using nitrous oxide, as I said, it's generally controversial whether nitrous oxide is used or not, but the recommendation is not to use it. But in case you're using it, then stop nitrous oxide at once, put the patient on 100% oxygen, and then fluid and vasopressors. Remember that carbon dioxide is a very soluble gas. That's one of the properties why it's used in laparoscopy. So hopefully then it will be absorbed soon in the system, and the body will get rid of it.
Okay, thank you for that response. So really what is important is that we are vigilant,
Vigilant,
right?
yes, very
Yes,
vigilant.
vigilance is really the key for this. And Dr. Felicia, one of the questions now is that you talked about pain management. They'd like to know the benefit of epidural anesthesia in relation to this over the infiltration, NSAIDs, and opioids.
Now, epidural, by epidural, you're referring to lumbar epidural, or just?
I'm not sure about. So, like for example, it's lumbar epidural. I'm not sure they were talking about a lumbar epidural or a
Shoulder epidural?
caudal.
Yeah.
Yeah.
Yeah. You see, I tend not to do invasive procedures like caudal and lumbar epidural for laparoscopic surgery if it's just a simple hernia. And one of the studies I quoted showing that the local infiltration and even simple analgesic are as good, comparable to epidural, because epidural is a bit more invasive. And I always think it's overkill to do such an invasive procedure for simple surgery. So I don't do that. I tend to just give local infiltration and simple analgesic.
So maybe it means that being simple is better.
I think that's what the recommendation that we've gone through, even for adults, start with simple analgesic. Yes.
So that we can identify if we do have complications where it might be coming from, right?
Yes.
So, Dr. Nada, there was a question here because, well, the question was something about what kind of measures do we do to reduce the volume of residual gas after laparoscopy? Because apparently the surgeons are not aware of the effect of the gas. Of course, what can you say about this question, Dr.
The volume of insufflation gas, yeah. So
Yes.
when you use
I think it's about the residual gas, doctor, after laparoscopy. So you insufflate and then you displate, and then there's a residual gas.
residual gas, yeah. So basically what we do is I would try to drain it as much as possible. You saw the video that we try to, I open up as soon as I finish the operation, I open up the ports. So the air, the gas comes up very nicely, and very gently put pressure on top and bottom end so that the gas will come out to the middle port. And very rarely I have problems with shoulder tip pain. In kids, I hardly see it. I've not, maybe one in the last 10 years or so, I've seen one to shoulder tip pain. It's very rare that we get this shoulder tip pain. I think Dr. Felicia will agree. It's not common. So generally, I don't have this issue. I think it's also to do with the rate of insufflation. So very low pressures, low flow is, I think, very key to how we kind of handle pain. So sudden distension is, I think, suddenly, your tummy, your tissues are stretched too much. Suddenly, it can cause more pain. I think, it basically is something that I've been taught, and I just follow the same principles. I don't change in any way. if I don't hurry things up, because I think by hurrying things up and by skipping steps, you tend to cause issues.
Um, okay. Dr. Fauzia, there was also a question put to the box wherein they asked about the long recruitment before extubation. Dr. Nada gave his opinion on this. What do you think about this after just long recruitment before extubation in children?
Um, well, I don't do it routinely, but I guess it depends
Mhm.
on the type of procedure and the length of the procedure. So if the procedure has been long, complex procedure, then perhaps, it's a good
Can I
idea
just
to
say
do it.
something? One of the methods of reducing shoulder pain is
Mhm.
lung recruitment. And in the adult, what they do is to uh, increase the positive pressure
Mhm.
and pushing the diaphragm down and hoping that, and you open the port to atmosphere and hoping that all the gas will come out from the abdomen. That's one of the ways that we can use to decrease shoulder pain.
Okay. Also for children, that would be safe to do.
Yeah, I do that for children, not so much for the gas, is to open up all the airways that have been
Yeah.
collapsed during your distension of the abdomen. Yeah.
All right. Okay. There was a question now. Uh, maybe I'll put it to everybody right now. How long at most should laparoscopy in neonates go if we consider safety physiologically? So they're asking probably about the duration. I guess, especially in countries wherein it might be still something new. So, how long do you think it should go? So, could you maybe everyone can give their opinion about this and how to go about this when the duration is going longer than expected?
So the age also
Dr.
matters.
Nada?
So for a neonate, I'll be very careful, especially when doing a diaphragmatic hernia, because the lungs are already compromised before we start. So for a diaphragmatic hernia, I'd give about 1.5 hours or so. For an abdominal procedure where a child has got no other comorbid issues, like for example, I do a middle atresia repair, I'll give you up to about 2 hours or so. So one of the things that I look at every 20 minutes, I'm looking at the clock and saying, okay, am I progressing? And then every 20 minutes also, I check with my anesthetist, look, everything's okay. Can we go on? And that's the way we need to reevaluate every time. So the progress of the surgery. So for me, if I'm going progressing, I'm not in the last 20 minutes, I haven't gone very far, I would consider doing an open procedure. Sometimes that's what we might need to decide. The older children, they are more robust. A child with no comorbid issue, for example, in 1 year old for a choledochal cyst, that can take a long time. Choledochal malformation can take sometimes 3-4 hours to do. And if as long as the child is safe, we are not causing any issues with the physiology too much, then we can go on up to that long.
Dr. Fauzia?
Yeah, I think I would agree with Dr. Nada. There are no hard and fast rules. So actually, it depends on the expertise of the surgeon and the changes that occur in the child. There is no hard and fast that you do it for an hour and then convert it to an open procedure.
All right. Dr. Felicia?
Yeah, I think I agree with Dr. Nada. It all depends on the condition of the patient at that time. How is the patient's condition, and whether we progress very far or just get stuck somewhere. I think we need to look at all this and work together with a surgeon.
Okay, thank you very much for your answers. And again, if I will wrap it all up, it points to communication, working together as a team, and of course, simplifying things so that everything will result in a good and a most wonderful outcome for our children. So unfortunately, to the audience, I'm sorry that we could not go any longer. There may be still more questions. We will try to answer them as we go along, and we will try to email them back to you. You will check our website. So can I return the ball to Dr. Usha?
Thank you very much, Linda. That was a very informative Q&A session. And I think there may be a few questions that are unanswered, but we will try and get our speakers to answer them and email the answers to you. So please be patient. Thank you so much for your participation. And please remember, the participants, you have a webinar survey to fill up at the end of this, and fill it up and email it off. Please enter your name and email address correctly. Excuse me. And our next webinar will be on the 21st of February. And the topic would be pediatric perioperative fluid management. Details of the webinar will be sent out by flyer as soon as it's ready. Thank you so much for your participation today. Do remember to visit our website where this talk will be uploaded, where we are available on the ASPA website. We are also available on Facebook and on YouTube. The video will be loaded up there. I would like to thank our three speakers, Dr. Nada, Dr. Fauzia, and Dr. Felicia, for taking part, for their effort and their time. Thank you to Dr. Alinda, and thank you to Dr. Teddy Fabila in Singapore, who is the pillar of our IT for this webinar. Thank you all. We hope you enjoyed this session. Have a nice evening.